Welcome. My name is Jacqueline Dugan, and I'm here to support our esteemed speaker, Dr. Pamela Scarborough, for today's webinar. We're so glad y'all are here today. We'll officially get started in just a few minutes, so feel free to settle in, get your water, get your notes if you want to take notes. In the meantime, if you have any questions during the presentation, please feel free to utilize the chat. It is working now. You can also use the Q&A feature, whichever you would prefer. I'll be keeping an eye on both. And we'll even pause Pamela in the moment if it is pertinent to the information that she's sharing. We will be linking several helpful resources that go along with today's presentation. I'm going to put that in the chat as well. So be on the lookout for that here in just a little bit. I'll put a note out when I post that. Today's session is also being recorded, so you'll get a copy of this afterwards. And while we're waiting for a few more people to join us, I realize that not everyone knows who we are. So I'd love to just take a moment and share a little bit about who we are at United Wound Healing, as well as two important arms of our organization that we think you want to know about. So a little bit about us. In 2015, United Wound Healing was founded with a mission to provide better skin and wound care for patients by strengthening and supporting wound care teams within skilled nursing facilities. And at the time, we noticed that patients with wounds often had to travel from their facility to an outpatient wound care center, a process that was really uncomfortable, disruptive, and expensive. So we found that when a specialist could bring that care directly to the patient, outcomes were improved, satisfaction was increased, and costs also went down. Today, United Wound Healing operates in 4 states, Washington, Oregon, Idaho, and Utah, and we care for more than 15,000 new patients every year. Our skin and wound care specialists work alongside more than 400 skilled nursing facilities. Many of you on this call are partners with us. We thank you for being here. We are also proud to support 2 major initiatives that will extend our mission. First is Open Wound Research. And Open Wound Research is a research organization that's dedicated to working to make wound care research easier to conduct and replicate, make wound care more accessible and actionable for clinicians, decision makers, and industry partners, share data and tools using open source principles, and promote generative models that help us to advance knowledge in wound care. We're so excited about this. This is work that really matters to us. And if you want to learn more about what Open Wound Research is doing, I'll also drop a link to that in the chat as well. And secondly, one other arm that I want to share about is our fellowship program. We are incredibly proud to offer the nation's first fellowship dedicated exclusively to training advanced practice providers in wound management, dermatology, and limb preservation. The 12-month program empowers postgraduate nurse practitioners and physician's assistants with clinical expertise, board certifications, and a compassionate approach needed to lead this vital specialty. If you're passionate about improving outcomes and serving medically complex and geriatric populations, which I know many of you are doing the work that you do, this fellowship is an incredible opportunity. And so I'll also share a link to learn more about that if that is something that interests you. So now that I have given all of our housekeeping and our updates, we're right at a few minutes after, so I'm going to go ahead and get us started here and introduce today's speaker, Dr. Pamela Scarborough. Dr. Scarborough is the Director of Education as well as the fellowship program that I just mentioned here at United Wound Healing. Her healthcare career as a physical therapist spans over 40 years, and she has practiced across the entire continuum of care. She presents nationally on wound prevention and management topics and is a founding faculty member of the Wound Certification Prep Course, an intensive review course designed to help clinicians prepare for and pass their wound certification board exams, which she has taught for over 20 years. Pamela, I'm going to let you kick us off.
Thank you for that, Jacqueline. Appreciate it very much. Well, welcome everyone. This is the kickoff for 12 months. This is a 12-month curriculum. I do it with some of our corporate accounts, some of which are on this call today. They've been offered the 12-month curriculum, and we think this is so important that we have brought it to, this is the first time it's been on the national stage. So we are very, very proud to give this to you and that you are here today to do this. One of the first things I have to do is to do my disclaimer. So this information is provided for informational purposes only. Patient care decisions should be based on relevant clinical guidelines, including current evidence-based literature, state and federal guidelines, such as from CMS, such as the document we're going to use today. This is a federally generated document on preventing pressure injuries in the long-term care setting. And this is one of the documents to help you begin your process of framing up your pressure injury prevention program. And whatever facility protocols that you have need to be part of your decision-making process. Decision for wound management should be based on a holistic review of that patient's clinical condition. We have to look at the whole patient, our resident, and not just the hole in the patient or resident. And if we only look at the whole, we're going to set ourselves up for failure for our ultimate goals for prevention and for healing. So we have to look at the whole patient. So the clinical team members are encouraged to rely on your training and expertise. If you did not go into specific training for wound management, if you've not had a mentor, if you've not studied, then you don't know wound prevention and management. It is an entire specialty with a mammoth amount of knowledge. I've been doing this for 40 years. I've been around wounds. In the last 20 years, 25 years, that's all I've focused on. Well, diabetes too. But the point is, I am still learning all the time after 40 years of doing this, 20 focused on wound management. So you have to get the education. And so this is a good place to start if you've never had any. So and so this is the beginning of your training. Education is the beginning of training. Education is not the end all. Education is the beginning. So this education that we're doing today hopefully turns into your knowledge. That means you've internalized it. Knowledge is internalized. And then you take that knowledge and turn it into skills. So you have 3 different steps to get the knowledge that you need to be able to do what you want to do. So you want to rely on your training, your expertise, which means you had to go into training, as well as any and all available information for that person, those circumstances, where these things are happening prior to making management or treatment decisions for any individual patient. So our objectives today are, there's only 2, to identify the components of the Agency for Healthcare Quality and Research program for nursing homes on-time prevention self-assessment tool. This tool is for you to look at your facility's processes for preventing pressure injuries and to try to find the hole. So that's what we're going to try to do, to relate the findings. So Jacqueline, I have put this in Jacqueline's putting this information in the chat right now. You might want to download the document and go through it. You might even, if you have access to a printer, you might even print it and start your process today, now, looking for holes in your system and identifying those, because that's what we're trying to do. You want to look at your facility's current pressure injury program to find the areas that are working well and those that need improvement. That's where your holes are. You can't fix anything until you identify the problem. So that's what this talk is about today, looking to find the holes and plug them up. So you have 4 handouts today. You have the PowerPoint presentation, which you will end up every single time we do this. You're going to get a PowerPoint presentation, 2 slides per page in color. This is a visual discipline. Black and white is not going to serve you. You need to be able to see the colors of the tissues, the colors of the skin. So color is very important as we're trying to learn wound management. Your AHRQ document has been given to you, F686, and I usually carve out the different sections from either the MDS or from the State Operations Manual Guidance to Surveyors, which is what F686 is. So we carve that out. You don't have to go through all 900 pages. You just have to go through the 20-something pages that has to do with wounds. And then your MDS section M. I carved that out for you. And these tools, your F686 and MDS section M, if you are a trainer, if you are a DON, DNS, and you have to be responsible for the clinical education and knowledge in your buildings, you want to use these 2 tools to ensure that your people know what the regulations are that go back to the clinical best practices for wound prevention and management from a regulatory perspective. You cannot meet your regulations if you don't know what your regulations say. So the F686 and the State Operations Manual Guidance to Surveyor gives you the regulations for your clinical practice. Be sure that you look at that and that you do your knowledge, your testing. I hope you're doing competencies and at least doing verbal testing, maybe written testing. on the regulations. And then the MDS Section M, oh my, the education in both of these for your new nurses that are coming in, or anyone new, your therapist, your dietitians, it doesn't matter who's coming in. They need to look at the regulations around their specialty and how these regulations work with the interdisciplinary team. So this is your state operations manual guidance to surveyors. We have an advanced copy out right now, which is nice because whenever you look at your state operations manual or really anything that CMS does regarding the regulations, the MDS Section M, if there's something new, they put it in red. So you always know what's new. Every time we get a new one, I go into the first, because I know my regulations, particularly around wounds. So I go looking for the red, what has changed, what's been updated. And they have several things that have been updated. Not so much in F686, but in F880. So this is your state operations, Appendix PP, guidance to surveyors, and you want to ensure that all of your people that are working with wounds know F684, F686, and F880. These are the three tags, the three primary tags that are going to get you in trouble, and each tag will elicit another whole set of tags that the surveyor is supposed to go look at when you get any one of these three. So and you want to look at that too. At the very bottom of the state operations manual, that whatever tag you're looking at, F686, F684, it gives you at the very bottom all the tags that the surveyor is going to look at related to that particular F tag. And it's important that you look at all of that. So in F686, it talks about how the comprehensive assessment is what you're going to use to provide the basis for looking at how you're going to look at these people who are at risk for pressure injuries, or they already have a pressure ulcer injury. Either it was present on admission or was facility acquired. And what we're supposed to be doing is determine what the risk level is for this person. So a determination, and this is a very interesting statement. Look at this statement with me. A determination that a resident is at risk for developing a pressure ulcer injury. You've done your braid and you've got your risk score, and they are definitely at risk. Probably everybody in our buildings are at risk for pressure injuries. Probably. We'll talk about that later as we go down the road. So they have, just because they have the risk for developing a pressure injury and its significant implications for preventive strategies need to be put in place. But even if that person does not, they have a risk for a pressure injury, but they don't get a pressure injury, if you don't show that you have the strategies in place to prevent a pressure injury for a person at risk for a pressure injury, you can still get an F tag even if they didn't get a pressure injury. I know, who would think? But that's what this says, a determination that a resident as at risk, you describe them at risk, got their risk level, for developing a pressure ulcer injury has significant implications for preventive treatment and strategies, but does not by itself indicate that development of pressure injury was unavoidable. You have to show that you have every one of those strategies in place for unavoidability. Effective prevention and treatment are based on consistently, the key term there is consistently, providing routine and individualized interventions. So in F686, it talks about the unavoidable pressure injury and says that it starts based on the comprehensive assessment. The comprehensive assessment is not only the Braden and the head to toe skin assessment. If that's all we're doing, we're looking for our risk for pressure injuries or for any other organ issues that affect wound healing. It's already failed. The Braden by itself and the skin assessment is not going to give all of you, and that's next month, we're going to talk about this, it's not going to give you all your risk factors. So we have to have a comprehensive assessment of this person, and a resident needs to receive care consistent with the professional standards of practice. So I'm going to be giving you, over these 12 months, the professional standards of practice for wound prevention and management that meets both clinical and regulatory guidance, both of those. You want to be able to prevent pressure ulcers, and that person in your building doesn't develop a pressure ulcer. They don't get a facility-acquired pressure ulcer injury unless that clinical condition demonstrates they're unavoidable. So that's why we have to go beyond the head-to-toe skin assessment and the Braden and look at all of the organs that are impaired for our people in our buildings. A resident with a pressure ulcer is to receive the necessary treatment and services consistent with the professional standards of practice to promote healing, prevent infections, and prevent new ulcers from developing. So that's your charge. That's it. That's the basic charge for what we have to do relating to preventing pressure injuries in our buildings. So now we're going to go do an overview of your pressure ulcer injury prevention program together. Now, this is not every single component of it, but you have the document so you can get all of the components. I hit some of the highlights. No one person in your building, no one person causes a facility-acquired pressure injury. That means if you have a facility-acquired pressure injury, your system failed, not your people. Your system failed. And that's what this talk is about. It's about your system. We're going way beyond turning and repositioning and support surfaces. We're looking at everything globally. This is the document where you see over here on the right, it says PDF version. That has been uploaded for you in the chat if you'd like to download this. So the on-time pressure ulcer prevention self-assessment. This is self-assessment means your facility. That's what you're assessing. You're assessing the construct for your pressure injury prevention program. So it's designed to help the staff. It's to help you, the director of nursing, the assistant director of nursing, the administrator, all of the rehab leadership, the CNA, our CNAs. And we're going to talk about our CNAs in here, probably more than you want to. Doesn't matter. We got to talk about them because they're important. So you're supposed to look at how you currently identify your residents who have a change in their pressure ulcer risk. So that's why you do your risk assessment for 4 weeks in a row. So you can see what's going to happen to this person over that 4-week period when most of your facility-acquired pressure injuries happen present on admission. You have some things that come in present on admission, but a lot of times this person coming in present on admission is already ill. And then sometimes they get their pressure injuries very rapidly when they come into your building. You want to determine if they've had a change in risk, if they have new clinical interventions that are needed, because that's why we look and why we do our assessments every week. How do you determine what the interventions are for prevention of pressure injuries? This document is going to help you identify what current processes and structures you have in place. It's going to help you identify the gaps and places for improvement. This whole process we're doing can be used as part of your QAPI process for the initial prevention of pressure ulcer injuries and for preventing the recurrence of pressure ulcer injuries, which is one of our problems in our buildings, is the recidivism or the recurrence of these wounds. So the first step in preventing a pressure ulcer injury is identification of the resident at risk for developing pressure ulcer injuries, followed by the implementation of an appropriate individualized intervention care plan and monitoring for the effectiveness of these interventions to prevent this pressure ulcer. So a pressure ulcer injury can occur whenever pressure has impaired circulation to the tissue, and the facility must, that's a strong word, a facility must. When you see words like should, must, those are mandates. They're not suggestions. And I wouldn't even call them guidelines. Things like must, should, means you're supposed to be doing it. You have to identify whether the resident is at risk for developing or has a pressure ulcer injury on admission or thereafter. You want to evaluate the resident's specific risk factors and changes in that resident's condition that can impact the development or healing of a pressure ulcer injury, and then to implement, monitor, and modify the pressure injury prevention interventions to attempt to stabilize, reduce, or remove underlying risk factors. And if a pressure ulcer injury is present, then we're supposed to provide the treatment to heal it. And if we can't provide the treatment to heal it, we're supposed to document why not, and prevent the development of additional pressure injuries. So who, what, when, and where? Where are you in relation to your clinical and regulatory expectations? Where are you in your building? How do you have your pressure injury prevention program structured? Where do you find the documents that tell you about the clinical and regulatory expectations? We're going to be doing this for 12 months. You're going to have a library of current clinical information that comes from the science, it comes from best practices, it comes from consensus statements, it comes from guidelines, and you're probably going to have 50 to 60 documents over this 12-month series that you're going to be able to refer back to. You end up with a library. Where do you find the documents? I'm going to help you with that. What tools are there that can assist all of us in putting together a pressure ulcer prevention and treatment program that meets our clinical and regulatory guidelines? We cannot do that without the documents that you're going to be given. This doesn't come out of anybody's head. It doesn't just come out. A lot of experience. If you have years and years and years of experience, you might be able to put this together, but not if you don't have the experience and you don't have the documents. Who in the building needs to know about the clinical and regulatory expectations? Where do you start? That's what we're looking at today. What are some of the things that you're going to find that help you to pin down, where do I need to start this process? It's daunting. And if you recognize that you have problems, oftentimes it takes 6 months to a year for a facility to shore up everything. So do not expect things to change in a week or two. You have to change your systems. Where do you start and how do you know you're making progress? Well, we understand how we know we're making progress. That's your QAPI, your quality assessment and performance improvement processes that are taking place as you watch the number of pressure injuries that are avoidable go down in your buildings. You're still going to have end of life issues and pressure injuries you cannot prevent. But by the time we get finished with this year, you're going to understand how you need to document that and show CMS that this was either an unavoidable pressure injury or skin failure. That's a few months down the road, but we're going to get there. So when we look at this tool, it has 4 sections. It has the first section is screening for pressure ulcer risk, which is what we do usually with the Braden. We're going to talk about that. And then we go into pressure ulcer prevention plan, your communication practices, and we're going to do just a little snippet, and I do mean a small snippet, on your root cause analysis when we're doing our investigations to figure out what went wrong with our system, not with our people, with our system. So why do we use a risk assessment tool? What you'll notice when I do programs for you, you know exactly where I got that information most of the time. And the top left corner will tell you if it's a regulatory document and which regulatory document it is. So if it's a very important document, oftentimes the top left corner, or I'll have it on the bottom of the screen to tell you where that resource is. And it says in F686 that all the requirements do not mandate, they even use the word mandate, I love that, which means you have to do it. There's no wiggle room there. It doesn't mandate the use of any specific tool. You do not have to use the Braden. I've got some groups in California, or one big group that does not use the Braden anymore. They blame the Braden for having a lawsuit that they had to pay a lot of money for, but it wasn't the Braden that actually got them in trouble. It was using the Braden only and not using it correctly. That's next month. So you don't have to use the Braden or any specific tool, but you do have to use your resident assessment instrument. The RAI, the resident assessment instrument, tells you how to code and report the MDS. That is important. And if there are any MDS coordinators, please raise your hand so Jacqueline can say hello to you. Our MDS coordinators are very, very important also. And their MDS coordinators are only as good as the information that you give them or that they go search out. So you need to be sure that you give them the right information on staging and all that kind of stuff. So the RAI, you have to use that. There's several different validated instruments that you can use. There's the Norton, the Braden, the Gosnell, to help you assess your risk factor. But we're going to talk risk factors, but we're going to talk about that really next month. So research has shown that in a skilled nursing facility, 80% of the pressure ulcer injuries develop within the first few weeks. Remember, oftentimes when these people are coming into your building, you want to look at all their organs. And nurses, you want to focus. Your medical directors want to focus. All of us want to focus on these organs. Are the organs being cared for optimally so that you can prevent pressure injuries or so that we can heal wounds? As the organs continue to decline, your pressure injury prevention and your wound healing opportunities decline along with the organs. So you have to look at the organs. So that's why 80% are going to get pressure injuries within the first 2 weeks. Had you done that assessment of this person thoroughly, you probably would have gone ahead and put in a pressure redistribution mattress, maybe a heel lift if they're immobile and laying on their backs, and you want to make sure they don't get a heel pressure injury. So sometimes we have to put in these prevention strategies on admission and not wait until they get a stage 1, 2, and beyond pressure injury. And then 96% of them develop within 3 weeks of admission. So these are people usually that are coming in, they're already in organ failure, and then the skin fails too, and you end up with what's called a pressure injury. And a lot of these are related to pressure, but they're related to pressure in conjunction with organ failure. So section 1 of this particular document is screening for your pressure ulcer risk. So some of these, I even have what it looks like in this document to bring you back visually to what you're going to be doing when you sit down with your team, your interdisciplinary team, your CNA, your nurses, your medical director, your administrator, your dietitian, your maintenance, CNAs. They're all in your team meetings as you do this. So number 1, does your facility have a pressure ulcer risk assessment policy. The recommendation from the National Pressure Injury Advisory Panel and Centers for Medicaid and Medicare Services is that every building and organization has a pressure ulcer injury risk assessment policy. And in this policy, does it talk about which clinical areas you're going to cover? The timing or frequency? Yes, we have pretty much mandated timing and frequency for our risk assessments. Your documentation requirements and your communication to the team. How do you get this information for risk, for pressure injury out to the interdisciplinary team? How do you do that? That's important. And as you'll see, some of the numbers aren't sequential because I might skip something because I picked the things that I thought that we had as holes in a lot of the things we do in our buildings. Does your facility provide training? I love this question. Does your facility provide training to the nursing staff on how to accurately assess for pressure ulcer risk? Yes or no? There's no equivocation. Yes or no? So note that they are not asking if the nurses came to you trained in how to do the Braden or any other risk assessment process. It's asking you, are you providing the training and validating that your nurses know how to do a thorough wound assessment? And there's also the recommendation for competencies. So do you provide training? Do you know that nurse knows how to use the Braden and knows what Dr. Braden said to do when you have certain criteria that causes you to need to go to the next level of risk? And if you don't know what I'm talking about, please be here next month. You need me. Does the pressure ulcer risk assessment use a standardized tool, for example, the Braden or the Norton tool that it's actually mentioned? Now, you can do a pressure ulcer risk assessment, I've just said to you, without doing the Braden or any other formal tool. You just have to use the RAI, and that's how we have to report on the MDS. You can review the medical record. You should, not can do, you should review the medical record in detail. Extract each pressure injury risk factor. Do they have decreased? Are they in heart failure? Are they in stage 4 kidney failure? Are they on dialysis? All of those are risk factors for pressure injury. Organ failure is a risk factor for pressure injury. So each risk factor, you're going to extract it, and you're going to get some of that from the medical record. You want to look at all your organ systems impairments. You're going to review your labs. You have to look at the labs. They point to where the organs are in failure. They're going to point to your multi-organ issues. There's going to be places, nurses, no matter what your level of nursing is, that you're going to have to bring up your level of knowledge on some of this information if you want to do this well and work hand in hand with your providers. Nurses, you don't get to stay here and the providers stay here and the therapists stay here in our silos. We have to do interdisciplinary communication. So you want to review those labs that are going to point to your multi-organ issues. You're going to re-interview that resident if you can, or the family members if they're present, or the representatives for any other risk factors that may not be showing up in the medical record. Or you can do the Braden or another risk assessment tool. You can do that and review the medical record and interview the patient and residents. You can't just do the Braden by itself and the head to toe skin assessment. You cannot only perform the Braden and expect to pick up all of the pressure ulcer injury risk factors or organ impairments responsible for those risk factors. And skin failure. It's those organs that are in failure that cause skin failure also. We have over 100 risk factors. Over 100. The Braden gives you 6. These 6 things were originally put together by Dr. Braden and her team for the 6 things for which the nursing team could intervene. That's what this was. It was never meant to be the end all of the assessment process. There's over 100 risk factors. Is your team, and I'm asking you, please put in the chat, is your team picking up all of the risk factors? Jacqueline, if you'll look at that for me for just a minute, and then we'll come back to that. Do you think your team, based on what I've just said, is picking up all the risk factors for pressure injuries? So when are your residents screened? We know this. We do it on admission or readmission. When there's a change in condition, with each MDS risk assessment, which we do for 4 weeks, and then we do quarterly, when there's a weight loss has occurred. Here's the deal: weight loss, weight loss, weight loss. You've got to watch the weight. And this is another thing. When you have someone that's very, very overweight, you don't want them on a diet. We are not trying to lose weight when we're trying to heal wounds. Do not put this person in a catabolic state when you're trying to close wounds. And nurses and CNAs, watch that weight. When this person starts losing weight, that's usually a trigger that they're going into another level of multi-organ failure. Watch that weight. That's going to put them at higher risk for pressure injuries and much higher risk for non-healing if they are losing weight while we have an open wound. So watch that weight. Now, when you have, and document this stuff, document it. So now we have a change in meal intake, a change in fluid intake, a change in mobility, a change in continence or incontinence, and a change in communication. Who is the first person? What do we have in the chat? I'm looking to see, what do we got in the chat? If anybody, there's it, okay. The question is, in general, who would be the first person in your building to notice these changes? Who's going to be the first person in your building? Put it in the chat to notice these changes. CNA, you got that right. That's the first person to notice these changes. So we have to teach the CNAs all of the things that you want them to be reporting to you. A lot of these things they're already reporting. Right, the CNA. Does your facility pressure ulcer risk assessment activities include a comprehensive skin assessment or inspection? Of course it does. Is it being done comprehensively by the nurses that are doing it? That is something for you to check, for you to do a competency check. So a comprehensive, this is the definition, a comprehensive skin assessment is defined as a full head to toe, front to back assessment of the skin, the body's largest organ, for any breakdown or reddened area. This includes attention to all bony prominences, including the ears, the scalp, in between the toes, etc. And then this is my note to you. If the comprehensive skin assessment or inspection is not done appropriately and thoroughly for each patient or resident, then your present on admission process and your pressure ulcer injury prevention program is invalid from the start. We have to have a full risk assessment that goes beyond the Braden and the skin assessment. And if we're not doing this appropriately, then our whole present on admission process is faulty from the very beginning of somebody coming into our building. Now we're going to look at your pressure ulcer prevention plan. What do you include in your prevention plan? Let's look at this together and be sure you document. Give your building, give your nurses, give your CNAs, give your rehab, give everyone credit for everything they do. Be sure it's documented. How you're caring for this person, what you've done for them, what their turning schedule is. Be sure everything is documented. So the question is, do you develop a care plan for residents at risk for your pressure injuries? All right, let's look at our Braden scores. So an at-risk score is 15 to 18. So that's low risk, at risk. And it says that, do you develop a care plan for people at risk? And if you don't do a care plan, skip to section 3. Don't anybody skip on this. Please don't skip on this. Now, when it says at risk, that does not mean no risk. It means low risk. And even low risk is a risk for a pressure injury. And I want you to think about our population. Think about our population. How many people in your buildings have no risk for pressure injury? How many people in your building, the only ones that might not, in my opinion, how many people, I'm looking at the CNA, how many people do you think it is? Or write in here who's not who's not at risk in my building for pressure injury, and say what kind of patients you have or residents that aren't at risk. The only ones I can think of is maybe people that come in for rehab. They've had a total joint, but they're usually total joint replacement. They're usually already up and moving. Maybe your total joint replacements, but any other disease or organ system that brought these people into your building. How many people are at risk for pressure injury? Are not at risk for pressure injury in your building? Yes. Yes. No one. No one. They're all at risk. Absolutely. They're all at risk. If they're staying in your building for any length of time, they're at risk. So be very careful if you're if you are doing your Braden or something along that line and you say there's no risk. Think, is there truly no risk? Now, does your plan include daily skin assessment of pressure points? So these are your bony prominences. That's number 3. And 3A, does your daily assessment assess the following areas? And it talks, here's your sacrum, your ischium, your trochanters, your heels, your elbows, the back of the head, the ears, and nose. So who is best positioned every day to do a skin sweep, to look at the skin? I'm not talking about skin assessment. I'm saying skin sweep. Who is positioned for that? I'm looking to see who is positioned for that. Yes, it's your CNAs. Absolutely. Your CNAs, when they're dressing the patients, undressing the patients, cleaning the patients up, they are best positioned. In 70 to 80% of the task for watching and preventing pressure injuries falls on the shoulders of the CNA. Falls on the shoulders of the CNA. Are they getting the information they need? Do they know their bony prominences? Do they know what you're looking for? Give them the terms. They're smart people too. Give them the terms and help them. Understand that tissue tolerance for every person is different. And there are going to be people in your building that have very low tissue tolerance for any type of pressure or trauma. So the ability of tissue tolerance is defined as the ability of both the skin and underlying supporting structures to endure pressure without injury. Tissue tolerance is often decreased in the long-term population due to the multiple health issues. You go to bed at night and you may be able to lay there for 4 or 5, 6 hours without moving. I know my husband does because the cat lays between his legs and so he can't turn over. He doesn't wake up with a pressure injury. All his organs are working great and we have him on a nice bed and we have sheets that are cool. If you have any sheets that are polyester that are going to be hot, your patients and residents are going to sweat, and their skin is going to have a higher skin temperature, and they're going to be at higher risk for pressure injuries. So even the bed materials make a difference for your risk. Do your CNAs know all of these areas, and do they know to report this? Can your CNA do skin sweeps for these bony prominences when they're doing their patient or resident care on a daily basis? So the importance, CNA see the resident skin more frequently than anybody else. Here I said it's 60 to 70%. Okay, 60 to 80% of these interventions fall on the shoulders of the CNA. It's not possible to have savvy, trained CNAs to be able to have a functional pressure injury prevention program. Your CNAs have to be trained and have to be savvy. They want to be. All the CNAs, they want to know this information to help. So they're as important as your DON or DNS, your medical director, your CNA is important as any other professional in that building. And so they have to have this information. Impress upon them how important they are for your wound prevention management. See if you can have maybe a CNA wound prevention and management lead or a CNA lead that really helps you to keep the CNAs up to speed on what they need to do. They're truly the mainstay of your prevention task. Does your plan include an assessment for pain? Of course it does. We all do our pain. Does your plan include an assessment for decreased mental status? Usually we know when our patients and residents come into the building with decreased mental status, and we do see that this decline is usually progressive. And when we look at mental status, it's often tied to mobility issues as dementia or Alzheimer's or whatever the issue is with the brain not functioning the way it needs to and impairing memory. It also impairs motor function oftentimes. And that person will begin to walk slower and slower and slower. So mobility issues within the context of dementia, oftentimes this person has to go sit in the chair more and then they have to go to the bed. So cognitive issues can be a risk factor for pressure injuries. And does your plan include an assessment for incontinence? Of course it does. Of course it does. Does your plan include an assessment for medical device related pressure injuries, which we have quite a few medical device related pressure injuries? Do recommendations for positioning include the following? Dealing with your medical devices such as oxygen tubing and catheters. We have to be sure that our patients and residents aren't laying on top of these lines. Either they occlude them, and even when they're on them, they can actually have indentations to their skin from the tubing. Is there guidance for avoiding friction and shear? That has to do with doing transfers and doing repositioning our patients and residents in the bed. We want to try to avoid friction and avoid shear. And we're going to talk about all these things as we go forward. Support surfaces. I have a whole talk for you on support surfaces. If you don't understand the terms immersion and envelopment, be sure you show up for the pressure injury prevention interventions program that we're going to do in a couple of months. And then the frequency of repositioning. So as you look at this, dealing with medical devices, avoiding friction and shear, making sure that the support surface is functioning, one of the people to help make sure the support surface is functioning, and doing the repositioning. Who's dealing with these multiple times a day? Who? I want to see who. I'm looking over here. Who? Yes, it's our CNAs. Absolutely. Absolutely. Does your plan include an assessment for friction and shear? Now, this question relates to immobility. People who have impaired or lack of mobility will have friction and shear issues, which negatively impact the skin. So if there's a mobility issue requiring assistance with transfers or positioning, then this person is going to be at higher risk for friction and shear injuries, putting them at higher risk for pressure ulcer injuries. So immobility is a huge, it's one of the, from a pressure injury, acquiring a pressure injury, it's one of the main reasons that people get pressure injuries. And even in very, very short periods of time, because the people are very sick, they can get a pressure injury very quickly. Does your plan include an assessment for muscle spasms? Now, that's really, nursing is usually going to look at this and say, yes, they're having muscle spasms, or yes, they have decreased joint range of motion. But as a therapist, I came and looked at this from a therapy perspective. What are some of the issues that create decreased range of motion, muscle spasms, or cramps? And it can be musculoskeletal issue, neurological damage, such as amyotrophic lateral sclerosis, strokes, head trauma, seizures, spinal cord injuries. It could be decreased blood flow to the area that can cause cramping, pain, and spasms. We have a lot of people in our buildings that are in pain in their lower extremities because they have severe arterial insufficiency. And my understanding is we're not taking care of this pain as well as we should, because in some cases our primary care physicians aren't helping us getting the opioids to the people that need the opioids because they are in horrible PAD pain. PAD pain, it's like angina of the heart. It's the oxygen isn't getting to the muscles. The muscles require the most oxygen to survive in your body of any other tissue. And when you are having arterial insufficiency in the lower legs, your wounds don't heal. There can be a lot of pain there also, and it has to do with managing the pain of peripheral arterial disease. And we're not doing that very well in some of our buildings. And that can cause spasms, cramps, and pain. Diminished nutrients such as vitamins, potassium, medications that can act as stimulants can cause muscle fasciculation. So there's a lot of things that can cause muscle spasms and cramp. And if you can, you want to try to ferret out. And it could be that a medication that's causing it. Does your plan include an assessment for immobility? Yes, your plan does. And there is a very specific methodology that the nurses are supposed to be doing, and it's in the GG section of the MDS. You're supposed to be giving a number to the mobility that a person has. You're supposed to actually code it with a number. They took this information from rehab and brought it to nursing. And so now nurses, I hope you're doing your GG section, because if you mess that one up, then we don't have a good idea of what this mobility impairment is for this person. So be sure you're looking at your GG section for mobility and that you're doing your scoring correctly. And if you need help with therapy, let them help you with this. If I have to use a gait belt, if I have to use my hand to put it on a person and stabilize them, there is a mobility issue or a fall risk, one of the two. Does your plan include an assessment for contractures? Yes, when we have contractures, that's going to be a mobility issue, and it's going to be often a positioning issue also. So contractures can signal a central or peripheral injury. People have have contractures, have higher risk for pressure injuries because they're usually stuck in a position that they're not able to move their arms or legs or hips the way they need to. So that puts them at higher risk for pressure injuries. So after comorbidities, assessing accurately for mobility impairments and implementing a mobility plan of care is one of the most important components of a pressure injury prevention program. You want to look at that bed mobility. Can they roll side to side? Can they scoot themselves up in bed? When you put that head of the bed down, they have the head of the bed up, they're eating, or they're reading, or whatever they're doing with the head of the bed up, you put that head of the bed down. Could they take themselves back up to the head of the bed? If the CNA or the nurse or the therapist has to take them at all to the head of the bed, they have a mobility issue if they can't move themselves up. So be sure you score that mobility issue correctly. Can they roll? Can they go from lying to sitting? If they can't go from lying to sitting, there's a mobility issue. And you don't ask them, nurses or therapists that happen to be on here. You make them show you. Don't ask them. You can do asking about nutrition, but not movement. They need to show you. Can they go from sit to stand with their assistive device, a cane, a walk, or whatever it might be, safely? If they cannot, there's a mobility issue. And this is your GG section for mobility. These are all of the things that we're supposed to be doing. MDS coordinators, you can't do this from your office. Somebody has to go do this. And if you're not doing it, then you're not getting it correct. And then this is how you score it. You're 1 to 6. This is how you score it. And even if you have to touch this person, if you have to hold them in any way, you are going to have issues with mobility. So there's over 100 risk factors. You want to be sure you're getting all of the risk factors. Section 3 talks about communication practices. Now, I changed something on this document. I never do that with a CMS document. I never change anything. And I always speak directly to what they put in their documentation. There is a word that was overlooked and it was an inappropriate word. So whoever did this was not a clinician. And I'm not saying they have to be a clinician. So this is what we're looking at. So communication practices indicate the date of the most recent training that you have. Excuse me, I'm sorry. I thought I turned my phone on silent and I didn't. I am so sorry. So conducting your accurate skin assessment, your nurses are supposed to do that. Look at the next one. It says conducting an accurate skin sweep CNAs. The CMS had the term assessment, conducting an accurate skin assessment. And I blanked it out and put sweep. Our CNAs do not do assessments, and we wanted to use the correct term. And they do very important sweeps, but that is not the same thing as an assessment. And have you done training on effective positioning for the nurses and the CNAs on skincare? Documentation. Have you trained the CNAs how to do the documentation for a meal and fluid intake and positioning? Section 4, when we go to section 4, this is your root cause analysis. You are really mandated. I hope y'all are doing your root cause analysis because that's something we're supposed to be doing. You have a facility acquired pressure injury. You have to do a root cause analysis to absolutely determine whether or not that is avoidable or unavoidable, or whether it's an end of life wound, or whether it's a pressure injury. So you do an investigation using the root cause analysis construct. And you can get those documents online. There's all kinds of things online. So you need your root cause analysis construct. Your root cause analysis is a well-recognized way of offering a framework for reviewing patient safety incidents, investigations, and complaints by patients and families. This process can identify what, how, and why patient safety incidents such as pressure ulcers have happened. So you want to figure out where in the building are we having our pressure injuries? What type of patients are we having our pressure injuries in? Is our intake process capturing the risk that we need to capture on admission? Sometimes you have to start the end of life conversation and the potential for skin failure on admission. If these people are in multi-organ failure when they come into your building, you are now a step-down unit for acute care. We had people in our buildings 10 years ago, they would not be in our buildings. They are in our buildings now, and we have to live with it. But it means that we have to increase our clinical knowledge to be able to take care of these people that are sicker than we've ever had to take care of, and try not to get them back to the hospital. They don't want readmissions. So we have to know everything that's wrong and make sure that the providers are helping us to keep these organs at the peak potential for that particular person at their particular place as they're going through their decline in your building. And all these people are going to go through decline in your building if they're going to stay there as residents. They're going to go someplace else. That's a different story. So your root cause analysis should be a core component of the review process to show how your system failed, not the people, the system. Or to validate that pressure ulcer injury was unavoidable, including being a Kennedy terminal ulcer. And we're going to talk about this a few months down the road. Maybe it's skin failure or an end of life, terminal tissue death, and the person's on hospice or something like this. And it was not a pressure injury. That person is dying and the skin's dying also. So this should be part of your quality assessment and performance improvement process, defining the process, collecting the data, identifying the possible causal factors, identifying that root cause, and then recommending and implementing the solutions. What in your system has failed? And this can provide the facility information for your pressure injury program development updates. You may need to do some updates. So in section 4, this is what it looks like. Investigations for your root cause analysis. Did you investigate each new in-house pressure ulcer according to your facility's policies and guidelines? Do you have a policy and guideline for doing your root cause analysis? Yes, no, or you're not sure. Do you investigate each new in-house pressure ulcer in a root cause framework? That is the expectation. I'm not sure that it's happening. Yes, no, or you're not sure. And if no or not sure, stop here, it says. It stops here because it's not going to do you any good. If you don't have this in process, then just stop here. So, but if you do, in the course of your root cause analysis, do you look at the most recent pressure ulcer risk screen? Did you look at the most recent Braden? And we're going to talk about that. And we're talking about cloning and copying and not doing our own work. And I'm a physical therapist. So what I'm speaking to is what other nurses are telling me happens, that sometimes the Braden is cloned and maybe there wasn't a brand new one done every time that our policy said that it needed to be done. So we're going to talk about that more. And I even have a legal nurse consultant that gave me some information that she wanted to be sure that I share with y'all on that. So the point is, this, and also the surveyors, nurses, just know this. Surveyors go back and they will look at your Braden. And if your Braden looks the same all the time, they're going to wonder, did you do a new one or did you clone it? Okay, so that's your, and if yes, if, let's see, in the course of your root cause analysis, did you look at the most recent screen? And the answer is yes. Did you check the accuracy of the screen? Did you check the accuracy of the screen? CMS is questioning our Bradens. They're questioning whether we're doing our risk assessments thoroughly. That's what that was. In the course of your root cause analysis, do you check to see if the resident's status, if the risk status of the resident has changed? And then if yes, would your investigation include any of the following factors as affecting your risk for pressure ulcer? So if they get a facility acquired pressure injury in your building and you're trying to figure out, is this unavoidable or could we have avoided it? These are the things that some of the things that you're looking at. And I'm going to add number H, look at your organs. Go back and look at your organs. Go back and look at your last lab values and get current lab values and see if these lab values are changing, pointing to organ failure. So your basic root cause analysis considerations, you gather and review the documents that are related to the issue, such as the medical records, your interdisciplinary notes, your CNA reporting, interview the involved parties, because the surveyor is going to interview the involved parties. So I suggest you do that before the surveyors do it. They're going to talk to the nurses. They're going to talk to the CNAs. Are you talking to the nurses and CNAs, other providers and clinicians, your therapists, your dietitians? Are you looking at everybody that worked with this patient to see where the hole is in your process? Review your policies. This is a great place for finding holes. A great way to do it is to go through a root cause analysis and make sure whatever policies that are associated with pressure injury prevention are up to date and applicable to your care setting. Review the regulations associated with the issues. You're going to look at F686 and the 12 associated tags that go with it. It's not just 12 F686. Number 1, are you following the physician orders? Number 2, and there's a whole list of things that they're going to check that F tags go along with. That you want to look at the timeline of the event. When did this person come in? When did they start going downhill? And what did we do in the interim before they got to having that facility-acquired pressure injuries? You need to identify gaps in the knowledge of your staff. I have a document if you want it. Let Jacqueline know that you want it. And next time we come, I'll put it in the chat for you. And it's on what you need to know, what your nurses, your therapists, the minimum of the knowledge that you need to know to do pressure injury or wound management prevention and treatment in long-term care. I have a document where you look at all the skills and knowledge that people need to have. If you want the document, let Jacqueline know and we'll get it to you next time. Maybe that's a way to get you to come next time. So you want to identify the gaps in your staff's knowledge. You want to assess the barriers. What are the barriers? We have a lot of barriers in our care setting. What are the barriers for implementing this knowledge? Limited personnel. Oh my. Frequent turnover of staff. Oh my. Lack of outdated equipment or supplies. Oh my. Lack of personnel to provide professional knowledge. Now that's what we're doing. And CMS encourages you to do exactly what all of you are doing today on this call. They are encouraging you to look for experts in the areas that you need to level up the knowledge and have them come teach you. You don't have to do it all yourself, DNSs. The director of nursing services, or if you have an education team, you don't have to do it all. Use other people such as us that have this information and want to share it. So lack of outdated equipment, lack of personnel that provide not professional knowledge, plus many other barriers. What are your barriers? And please note this last note on the bottom here that's in this blue box. It says a root cause analysis is not meant to be punitive. It's to help you grow, and it's helped to your staff to grow, and for you to put in the best care planning that you can in your buildings. So in summary, for a successful pressure ulcer injury prevention program, a well-constructed system must be in place, which includes your policies and your procedures and your quality assessment and performance improvement processes, which is your root cause analysis. Everyone in the building should be aware and committed to the processes and expectations of your pressure injury prevention program, right down to the housekeeping people, all the way from your medical director and everyone in between. All of us, our clinical staff and our non-clinical staff, we're all in this together. Training and education must be provided, including competencies. Are you sure that your clinical staff is competent? A well-trained and empowered CNAs, they are critical to your pressure ulcer prevention program and associated processes. Your root cause analysis is the construct to assist you in identifying where your pressure injury prevention system broke down. If you don't have all the pressure ulcer prevention strategies in place for a resident, if you don't have all the pressure ulcer injury prevention strategies in place for a resident, you cannot claim it as unavoidable, nor can you claim it as skin failure unless you have care plans. You cannot run to my provider and say, Darren, fill this out, please, because this is an unavoidable pressure injury. It's skin failure. And Darren's going to have to say, well, where's all the risk factors that you care plan for? Oh, well, you have to have care plan for everything before you get to call it unavoidable. It is what it is. And document, document, document. So, summary, the necessary documentation. This is from a nurse. This is from a legal nurse consultant buddy of mine. She sent this over to me. Say, be sure you give all of your buildings this information. Assess and document every pressure injury risk, including the organ impairments. Educate and document the resident educate and document that you did this education for the resident, the family, the CNA, the staff on the importance of repositioning, and make sure it's individualized. Document issues with residents, non-adherence or non-compliance, and possible remedies. And if they won't take your remedies, you document it again, that you offered them a remedy, they wouldn't take it. And because we want to document, if they're part of the skin issues they're having, then we have to document it, report it to the medical director, report it to the primary care physician, report it to the wound specialist. If you have a wound specialist in your building, report it to the family, and let the patient or resident know that you are reporting this, that they are not going to comply, so that if there's ever a lawsuit or if the surveyor is saying that there's a problem here, you have all of this noncompliance documented. Don't get caught on noncompliance by the patient or the family. Be sure you document that, and notify the providers and document that notification with the date and time. Notify the family of the non-adherence and ask for assistance with education encouraging that resident's compliance. Update the care plan to meet the resident's needs or issues with non-compliance. Do not copy and paste previous documentation instead of creating a new note. Inconsistent documentation of wounds is an issue for the survey process and legal, is what this legal nurse consultant said. Ensure your CNAs are empowered to provide and to document daily on repositioning. There was one lawsuit that I know of that the reason the building did not get, that they were able to get out of the lawsuit or did not have to pay enormous fines, is because the CNAs documented and the treatment nurses documented to such a level that the jury, they went to a jury trial, could not say that this was negligence. And it had to do with that last one, that the CNAs were empowered. They were making sure that that repositioning was documented every day. It made all the difference in the world in that lawsuit. All right, we've been going an hour. What would you like to say? Anybody want to say anything to me? Thank you, Sarah Perry. Appreciate that. All right, next month, let's see. Next month, we are going to do your pressure ulcer risk assessment beyond the brain, the whole resident. Again, there's more than 100 risk factors for pressure ulcer injuries, and are your teams fully recognizing, assessing, and documenting and reporting all of them? And this program guides you through taking a holistic approach to the risk factors beyond the brain. Thursday, July the 10th. We hope we see you then. Thank you very much.